name's Dr. Chris Salerno, and I'll just tell you a little bit about myself while everyone still comes in here. I see a number of our attendees logging in now. I'm a general dentist. I practice in Melville, that's on Long Island in New York, and I actually don't place implants. I just restore them. I enjoy the team approach to patient care, where I will rely upon a great oral surgeon or a great periodontist to work alongside with me. They'll place the implant and I'll restore it. I do a number of restorations, both cement and screw retain. We'll get into, obviously, the difference between the two and what I do to cement them carefully. If you'll notice, the title of this course mentions peri-implantitis, how to prevent peri-implantitis. That's really a worst-case scenario. There are two peri-implant diseases that are on my radar. There's peri-implant mucositis, which is the lesser of the two, and then there's full-blown peri-implantitis, and we'll actually give definitions of that in the presentation today as well. Cement that is used to retain an implant restoration has been linked to causing peri-implant disease. Now, that's not to say that we shouldn't use cement in our restorations, because it's actually a wonderful way to restore an implant, and we'll go into the pros and cons versus cement versus screw retention. But I do think we have to be very careful, and we're only now really starting to investigate the different techniques and materials to use to safely and predictably restore these implants. So let's get started. This was a patient who presented to my office, about a year ago or so, and he had the restoration done about 3 years prior to this visit. And he said, it just never really felt right. And if you look at the tissue right around here, you can see it has kind of a rolled, plump look. It turns out that this patient actually had a gingival graft placed there because he had had some recession. So there's an interesting history with this case, right? And what I noticed is when I probed, you can see a probe going around the implant here, we started to bleed. And bleeding some more. And that is not normal. Now, first I should address, we do have some people that think it is not a good idea to probe around implants. And that is, in my opinion, a mistake. We should absolutely probe around implants. Now, let's be careful. Let's not, shove that thing right down there, but let's delicately probe the way we would probe around a natural tooth to detect the health of the implant and peri-implant tissue. There should not be bleeding. That is not normal. Some of you may know that we do expect to see a deeper probing depth around an implant, and that's considered normal. And that's true. Typically, we'll see an implant probing depth of, say, 5 millimeters, 6 millimeters, and that's not necessarily a sign of any disease. But we definitely shouldn't see suppuration, pus. We should not have any pain in the tissues, and we should certainly not see any bleeding. That's a sign of peri-implant mucositis, which we'll get into later. So with this patient, I probed the tissue. Again, he said he never really felt right, and see the bleeding, and I say, well, I agree with you. Something's not right here. Now we take our radiograph, which you see here. Now a careful eye, you'll probably detect what is the culprit, and that's the cement that's located right there. Now this is fortunate for us because in this particular case the cement is radio-opaque. We can actually see it on an X-ray. But I'll say that if we were to take this radiograph and not see any cement, we should still be suspicious that there is cement lying underneath the tissue. It may just be on the straight buccal or the straight lingual and not apparent on a radiograph. And in fact, there's been some studies done that show that if you see continued bleeding around an implant restoration that has been cemented, and despite the fact that you don't detect any cement either with an explorer tip or radiographically, you can suspect that there still may be some cement lurking underneath, quite a significant amount of the time. So this is very much a problem in our offices today. And what we're going to be discussing today is the restorative contours that lead to these kinds of problems. And it turns out that depending on the type of abutments you use, depending upon the type of crown contours you have, that you may be more or less likely to find excess cement lurking underneath and causing all kinds of problems. So we'll discuss those contours first. Then we'll spend most of the time doing that. Then we'll spend some time discussing how you can diagnose peri-implant mucositis and peri-implantitis. That is still a topic that is not very well understood, and we'll talk about how excess cement is a potential cause for that. And then finally, I'll talk with you about some of the cementation techniques that are out there. I'll share with you the one that I like to use that's been very predictable in my office. So first, let's discuss restorative contours. Well, there's a few different reasons why we may choose to use cement versus screw retention, and honestly what it comes down to is what we're comfortable with. The majority of dentists do use cement retention because it's what we're comfortable with for a natural crown and bridge. You know, I was raised, when I was educated at Stony Brook Dental School at the residency there, I was taught to do screw retention whenever possible. And the reason for that was of retrievability. And you'll see that as one of the factors that we consider. The retrievability of a restoration is quite important when it comes to implants. You may say, you know, if I cement a crown on a natural tooth, I use a permanent cement, I don't have to retrieve it. So why is it so important to retrieve a crown around an implant restoration? Well, that's what we're going to get into in a little bit when we discuss the different contours that are out there. But it comes down to hygiene. It comes down to some less natural contours that we find around implant restorations that allow that make the retrievability become a very appealing factor. Well, the good news is that we can retrieve predictably using cement. We just have to use the right cement. If you're using a permanent cement, a resin cement, for example, then the retrievability of that implant restoration is, well, it's just not existent. But if you're going to be using a cement such as Premier Cement or something that is designed specifically for implants, then you're able to get that right fit of retention but also retrievability. The other two big factors when deciding cement versus screw are aesthetics. You know, everyone knows that when we are doing screw retention, the aesthetics can be a little less desirable because we have a screw access hole that we have to contend with. Well, you know, depending upon the placement of the implant and use of angled abutments, we can correct that for, you know, to an extent. But certainly aesthetics are, you know, generally more positive with a cement retained restoration. And finally, there's the issue of passive fit. You know, I discuss quite a bit when I lecture and when I write about implant complications, and the force factors and the occlusal factors, the mechanics at play are very interesting and fascinating as we study these things. Suffice it to say that it is easier to achieve passive fit. That means unintended significant forces on the implant and the implant restoration complex when we cement. When we have multiple units, for example, that are screw retained, it is really critically important that we have accurately transferred the precise angulation of those implants to the laboratory so that they can make screw retained restorations that are splinted together. As we tighten those abutment screws down, if there is a discrepancy between what's in the mouth and what's on the model, we are introducing active fit. We are introducing force and torque into that system, and that causes a host of problems, from abutment screw loosening to stress around the implants and crystal bone loss. So passive fit is the key. And if we're cementing, we have a little bit of that wiggle room, that die spacer, if you will. And so without question, passive fit is much more achievable around with a cement retained restoration. So some pros and cons between using both of these systems, and for many reasons, including because it's what we're comfortable with, we do tend to cement restorations. Now here's an example of a real challenge. This was a patient that presented to my office with an implant ready to be restored, and as you can probably see, the platform is showing. This creates an issue. How are we going to mask this? Now this was the bisque try-in for the crown, and you can see we have created a flange of porcelain to just tuck over and hide that tissue and that metal collar. Unfortunately, we still have some metal exposed, so we have to add even more porcelain. And now this is how this restoration looks when it's all said and done. Now the patient was pleased. I wasn't so thrilled, but then again, we inherited a surgical complication. The implant wasn't placed apically enough, and we have to come up with some sort of cosmetic solution. Well, we have a cosmetic problem due to a surgical problem. We have a cosmetic solution, but that cosmetic solution has been solved by introducing a significant hygienic problem. We can't have it all. So this creates quite a bit of a problem, and this was a cemented restoration. Can we imagine the food and the hygienic issues that we might have that trap under that porcelain flange? For this to not be retrievable is a significant problem. Now, this is the kind of restoration that we would love to see. This happens to be a screw-retained provisional. We have certain contours here and here that are more natural. Certainly the example that I just showed before with that flange of porcelain is highly unnatural. Now, that's an extreme example, but still the point is that we sometimes have implant contours, the abutment and the crown, that are that more closely resemble a natural tooth and its crown, versus some other contours that are completely irregular. Now, here's a patient that presented to my office. He's going to be losing tooth number 8 because he has a diastema. He wanted to keep it. And you can actually see and appreciate the fracture here on the x-ray. So this tooth is a goner. Tooth was extracted, and this was an immediate temporary abutment that was poking out immediately after surgery, and we were able to immediately load this. And this is my technique. You can see that I have a clear matrix material that I made in the laboratory based on the initial model. I fit that over this particular system. There's this white plastic material that gets slid over the little abutment that sticks up. And I'm able to access that area. You can see a little hole there that I'll be able to squirt the bisacryl material in and form my abutment. And after a lot of careful, meticulous work, I'm able to get the basic shape of what the patient's tooth should be and link that down to the temporary abutment. Now, this takes a lot of time and a lot of attention, and my goal is to slowly but surely preserve and develop the soft tissue contours that allow a more anatomic contour of the abutment. This takes time, and I realize that this is something that's not always achievable, and even when it is achievable, it's not always done in our offices. So this is how he presented initially. This is how he looked after about a couple weeks of healing, and we let that sit until he was ready for his final restoration. But to really achieve these anatomic contours, and this was an immediate load situation, the earlier we can do it, the better. It can take a lot of work when the patient presents to your office with a circular healing abutment in their mouths, and you have to now try to bring those contours from a circle into a more anatomic form. This is how the soft tissue looked when we were getting ready to finalize. This is very much not the circle, but the familiar circle that we see with the healing abutment, and I was able to preserve this right away. Well, that's going to benefit the patient hygienically, but it's also going to be a benefit as far as when this restoration is cemented, it's easier to gain access to clean out any excess cement. So let's discuss a little bit the concept of an emergence profile. You can see here a natural tooth that has a crown margin, a PFM crown, a porcelain fused to metal crown that had been placed. Now, the discussion of emergence profiles, which is a very hot topic in implant dentistry today, well, this concept goes way back into the 70s when our colleague Dr. Stein had discussed with his lab technician what are the different restorative contours that we introduce, putting gold and PFM restorations on natural teeth. And then there was a very interesting study done by a colleague of his, a former student of his, Dr. Kroll, where he actually photographed the different kinds of emergence profiles that we see on teeth in 360 degrees. What these two dentists found is that by and large, the emergence profile of a tooth going from the root straight up through the height of contour is perfectly straight. There are some areas where there's a concavity or a convexity, but by and large, it is straight. Now, in this particular tooth, you can appreciate that this crown is over-contoured, and this leads to plaque accumulation. This leads to a host of issues. It makes for an unfriendly environment for the soft tissue. You can see how that angle is significantly divergent. Now, this is probably because that this particular tooth was underprepared. This is why our lab technicians yell at us and say, I want more room. Prep the tooth deeper so I can actually build out appropriate thickness of metal and porcelain, and then they can achieve that straight or more anatomic contour, an emergence profile. So that's all well understood for natural teeth. What's so interesting, though, is think about an implant for a moment. And here's an implant superimposed over this root. An implant is most often smaller in diameter than the tooth it replaces. And it's also a different shape, right? It's a circle, not a rhomboid or a triangle, or depending on the tooth that we're talking about. So almost by definition, our emergence profiles on our abutments and our crowns have to be divergent. They have to be over-contoured, so to speak, relative to the size of the implant, because we have to push that tissue out and get back to the height of contour and the anatomy that we're trying to capture in the natural tooth. Just to further illustrate that point, we see a tooth in cross-section, both horizontally and from the occlusal perspective. And when we place our implant here, you can see, again, you can see that the dimensions of that implant are smaller than that of the tooth it replaces. And occlusally, we have all kinds of geometry that we have to account for. A central incisor, as you see all the way on the right here, this is the implant, and we have to grow this often to a more triangular shape, as we, more oval as we move to the bicuspids, and so forth. This is a significant challenge, and it's not something that we always pay attention to in restorative dentistry. Sometimes we just take the impression and send it to the lab, and the lab will then sometimes carve out some soft tissue and develop that contour for us. Then when we go to insert the restoration, the patient says, ow, as we're now suddenly blanching their tissue. I much prefer to delicately and slowly develop that tissue over time with a provisional restoration, and then capture that information and send it to the lab so we have more anatomic contours. But that takes time and it takes money. So let's define some terms here. Here's a tooth that would appear as a pontic. We would call that a modified ridge lap if we were using pontic terminology rather. And there's this tissue surface underneath, this underlying prosthetic area that we have to pay attention to. Well, in the case of an implant, and you can see an implant here, and there's that prosthetic flange that we were discussing right here on the facial. So in this particular area, there was perhaps some sort of cosmetic concern, and we felt that we needed to extend this facially. So in this particular area, let's appreciate the different kinds of tissue that we have to respect. Again, there's still that underlying prosthetic mucosa. There's still this tissue that's just underneath our crown and our part of the abutment. But we also have the peri-implant sulcus mucosa. We still have the tissue that's in an adaptation to the abutment. So in this particular case, this abutment is a circular abutment. It is a straight emergence. No attention was paid to slowly develop the emergence into a more anatomical form. This is not divergent, it is perfectly straight. And many of our implant restorations do look like this if we haven't taken the time to develop these contours. So in this particular case, and any implant restoration, let's think in terms of these two types of tissue, the underlying prosthetic mucosa, which may be trapped under our unique contours, and then of course the sulcus, the peri-implant sulcus mucosa. And I'll just take a moment to get back to cement here. You can appreciate that if we are cementing a crown, we may have cement trapped in an area that is very difficult to remove. In addition, for hygienic reasons, we can get food and other kinds of debris in an area like this, and that is very difficult to maintain hygienically. So again, the retrievability of a restoration is quite important, certainly from a hygienic standpoint. So let's come up with some classifications of the different restorative contours that we see. And I will virtually guarantee that if you have done enough implant restorations that you have inserted all three types that I'm about to show you. First, let's just begin with classic pontic terminology. We would call this a full ridge lap. Notice how it fully covers the edentulous area. So think of your fixed partial dentures, your bridges. This is something that our prosthodontic teachers said, no, don't do that, because this is very difficult to get access from the buccal or from the lingual and maintain hygienically. There's no superfloss in the world that's going to easily negotiate that. So what we also tended to see and again, this is using traditional pontic terminology, a modified ridge lap, where this area was kind of chopped off, if you will, and it's much easier to maintain. Again, from a cosmetic perspective, this flange is still present to give the appearance of a longer tooth. Finally, if we had taken the time to modify the edentulous area, the pontic site, we might be able to develop a more ovate pontic, or some would call this a hygienic pontic if it was lifted from the tissue a little bit. But this still gives us the same idea of an emergence profile. It's still the same height of the crown, but this is far more cleansable. And so this concept of developing ovate pontics has been around for quite some time, and is still something that we look to do in our fixed partial dentures. So we have a full ridge lap, a modified ridge lap, and an ovate pontic. Well, let's build on that terminology when we talk about implants. And this comes from, I published a paper in RDH magazine, just taking a stab at beginning to name these contours. And that's the information on the paper right there. The first would be an anatomical emergence. This is like similar to what an ovate pontic is. It means we've taken the time to develop the tissue and take it from a circular cuff from the healing abutment and developed it into something that's more anatomic. It's going to be more hygienic and more cleansable. And this is an example of what this would look like. So here's our implant, and then the abutment and crown are divergent, because they get back to where the shape of a tooth used to be, the tooth that it replaces. And this is an example of one on radiograph. You can appreciate the implant, and then here's where the abutment starts, and then this is the crown that was cemented on top. And we don't have the effect where we have a pumpkin on a toothpick, is how I sometimes hear these referred to, where you have an circular implant, and then all of a sudden it blossoms out into a tooth very suddenly. We have taken the time to gradually develop these contours. This is anatomic. So you can imagine, as you're cementing this crown, this is very easy to clean and maintain. We're not going to be trapping anything here. And again, in addition to that, hygienically, this is going to be very easy to maintain. So this was a patient that came to my office with an Essex type retainer for his tooth. This was a tooth that had failed, and this was the healing abutment, the circular healing abutment that was on underneath. We took the time to develop these anatomic contours. You can see that this is where the implant platform would have ended, and we don't just continue this up in a straight fashion. This blossoms out naturally, anatomically, and then we'll have room to put our crown on top. As you can see here, here's the abutment. This was done with metal abutment, and the opaquing porcelain was placed on top, and then here is the crown on top. This is just in the bisque fashion. Now, some people out there really like to use zirconia abutments. By all means, you can do so. But again, the point here I want to take home is that this has been gradually developed, and it was done so lovingly with a provisional. And so now here's the final result in place. We're very pleased with this, and you can imagine, you know where the cement line is. This is going to be easy to clean up 360 degrees. Now, the next type of contour would be the modified ridge lap, what I call a modified ridge lap when it comes to implants. So a couple things I want to point out here. In this particular case, you have your implant. Maybe it's been placed a bit to the lingual or some other kind of implant surgical complication. But what's happened is we have not developed this contour. And so we get this 90-degree emergence. This tooth comes up to the tissue and then very quickly, poof, has to become a tooth. Now this is 90 degrees. This is greater than 90 degrees, I should say. This is an obtuse angle. That gives us some hope of being able to come in here and get some sort of cleansability. We have some sort of access. This yellow that you see here is just to highlight that tissue surface area. This, of course, would be flush against the gingiva, but we've exaggerated this for the point of example. So there's all of this area that has to be maintained hygienically, but this is also where we could potentially get cement when we're seating this. Now, this is a very common thing to see in the posterior. You could take all the time you want in the world developing an emergence profile on a molar, but mesio and distally in particular, this is very challenging to do. You can see here's a circular implant and tissue profile, but we have all of this tissue here that is very difficult. Even if we extended this just a little bit more with the tissue, we still have this area where stuff can get trapped underneath, whether it be cement or whether it be plaque and tartar. So this is what I would call a modified ridge lap. And when we're cementing a restoration like this, we have to be aware of where we might be potentially trapping cement. Just another illustration to really drive home that mesially and distally, this is very common to find on molars. This is a modified ridge lap. We have some hope of hygienic access here, but it's going to be difficult. I also tend to find this in anterior restorations if we have a surgical situation where the implant unfortunately hasn't been placed right down the pickle barrel, but a little bit to the lingual or the palatal, if you will. And then we have all of this area here where we still have to prop up tissue, but we may form a ledge. And this is an example of how that looks. And this was a screw retain restoration, but you can appreciate the depth of this abutment. This has been placed quite deep, and this is going to be very difficult for this patient to maintain. This is under tissue. This would be that peri-implant sulc, the underlying prosthetic mucosa, and this would be that the area of the abutment that contacts the peri-implant sulcus. Yet again in the molar, you're just looking at a restoration here. This happens to be screw retain, and you see, okay, that looks fine, but you can really appreciate when you look at the restoration, the kind of contours that we have to contend with, both hygienically and if this was cement retained in terms of cement. Finally, there's what I would call the full ridge lap when it comes to an implant restoration. And in this particular case, this can look, this is like the example I gave before, it can look like this or it can look like this. This is very tricky. In Pontic terminology, we would call this a modified ridge lap because we have access from, in this case, the lingual. But notice that there still is this flange down here. You cannot gain hygienic access through the abutment. So whether your full ridge lap looks like this or like this, it is still a full ridge lap as far as your implant restoration is concerned. And again, that's because of the presence of the abutment. We can't get through to the other side. So in this case, we have an acute angle, less than 90 degrees, where this implant restoration comes up and then takes a very sharp turn. We have less of a chance of hygienic access here, and we have less of a chance of being able to remove residual excess cement from the restoration. So this is really a tricky situation. Sometimes we're stuck with it, but if that's the case, we have to be very thoughtful when cementing the restoration. And this was the case I showed you before. This is an example of a full ridge lap. Here's the crown in that particular case. And again, if this was a Pontic connected on either side as part of a 3-unit bridge, we would say, oh, that's a modified ridge lap because we have this nice contour on this side. Well, it doesn't matter because this is not a Pontic. This is connected to an implant, and we cannot gain access from this side to clean this danger zone right here, to clean it from cement or to clean it from plaque. I would love if the contours of this tooth resembled something more like this, but that would be a very different surgical situation, and that's not what we were stuck with. As we finish up our discussion on contours, I just want to mention this to you about developing anatomical contours. This was a case of mine where a patient came back for an immediate load situation. This is the temporary abutment that came with this particular implant. And this is the restoration that I had fabricated. You can see part of that, that little plastic piece that fits over that gets picked up. Now, I developed this for this patient, and I thought, I did a great job. I'm developing an emergence profile. Isn't this exciting? I immediately loaded my implant. And this is what the tissue looked like after a few weeks. And you can see this ovoid shape, which is what the shape of a bicuspid would look like. And I'll just take that off there. Again, you can appreciate that. And I said, isn't this great? I'm developing an emergence profile. Well, no, I was not. I was not at all developing an emergence profile. I was just smothering the tissue into the shape of a bicuspid. It's very different. Look at this contour here. That's a full ridge lap. I'm just oppressing that tissue into the shape. That is not developing an emergence profile. I was not using this technique correctly. I've gotten better since then. So let's examine this for a moment. This is, without question, a full ridge lap. What would have been nice is to do something like a modified ridge lap. That would have been better. You can see here that this contour, let me bring it back over and overlay it for comparison. Now we're missing that acute angle and we've made it an obtuse angle. That would be better. That would be a better restoration. Let's move that over there. But still better than that would be this, to have a more anatomic restoration. It's more anatomical. I won't say that it's ideal. This implant is perhaps a bit shallow to very gradually develop that contour. Well, what we would love to see is a restoration that looks more like that. This is a much more gradual development of the emergence profile. But if you notice, in order to achieve that, do you see how this platform has been shifted apically from here, where the apex would be here? The platform now is down here. So one could say that the more that the implant is off bodily, the deeper that implant restoration should be placed to give us more running room to develop the accurate emergence profile. And that gets back to a study that was done by Potashnik in '98. He said for every millimeter that your implant has been placed palatally, you should sink it further an additional millimeter. So for every millimeter the implant is palatal, it should be apical another millimeter. And that speaks exactly to what you're seeing here. This was an implant that was placed a bit to the palatal. And so I don't have a lot of room to very quickly run all the way over to the buccal and compensate. But if that implant had been placed deeper apically, I would have been able to more gradually and more anatomically find that contour. So here is an example of me doing it correctly. This is a similar situation. We have a bicuspid and we need to immediately load this. Here is that little post sticking out. There it is. Here's the little cap. There it is. And now I'm going to use the technique I described before, and I can develop a correct emergence profile. And you can see that this is far more anatomical and more natural. So just showing that this particular implant system can be used correctly. It's the same tools, slightly different clinical situation, but your understanding of the contours and developing a natural emergence profile will help significantly. Between implants, this is one implant of temporary abutment, and this is another from another manufacturer implant abutment. And these are both suitable for screw retention, or I should say they're both suitable for cement retention. But you notice the difference. This particular contour is much more divergent. It kind of is doing the job for us, whereas this contour more closely represents that of the implant. And we'll put two implants on there. You can see that this is more of a straight emergence, and this is more divergent. And remember, with implants, we want to be more divergent. We want to swoop out anatomically to the natural contours of the tooth that we are hoping to replace. So now we'll put some gum tissue overlaid on here. And the other thing I want to impart to you is that if I'm going to be creating a restoration, I have to sneak out around here to the platform, perhaps even covering this metal collar if I truly want to expand this tissue. Down here, it's already being done for me. And with even deeper tissue, this can be a challenge with a temporary abutment like this, because I have, in this case, say, 4 or 5 millimeters of tissue that I have to stretch down into, whereas here, again, this contour extends all the way up. This is just driving home the point that not all temporary abutments are created equal, and we have to think about what contours they're providing for us and what we have to compensate for. So here's a temporary abutment, and you can see that I'm attracting some nice plaque underneath there. I like having my patients wear provisional abutments and provisional restorations before we do the final, so I can expand the tissue. And this is how this tissue is looking in this case. It looks a little beat up, and this was, I think, the culprit. I had a full ridge lap on this implant provisional. So I modified it to a modified ridge lap, and you can appreciate the difference between the two. The one on the right is far more cleansable. And if this indeed was a cement restoration, I'm able to get underneath there and clean away that excess far more easily on the right than on the left. But what's even better is if I can take the time to go from a modified ridge lap to an anatomical. When this restoration gets cemented, it is far simpler to get in and gain access and clean it out. So that's my take on restorative contours. They are not all created equal. Our parts and pieces are not all created equal. And the challenge for us is to take what the surgeon hands us, or if we're placing our own, what we hand ourselves, and really get them, this is where the magic comes in, where we develop something that not only looks good, but is sustainable. And certain contours will trap cement more frequently than others. So now let's talk about how we actually diagnose these conditions. There are really only two conditions, two peri-implant diseases that I am comfortable discussing. The third that you see here, Peri-Implantitis, I hate that term, and I'll tell you why. Well, the first is peri-implant mucositis. Let's just call this implant gingivitis. That's the simplest to understand, and that's more or less what it is. What we see is that there is bleeding, there's sometimes some pus, there can even be pain and mild discomfort or just an achiness feeling. Those are all signs of a peri-implant mucositis. What you should do when you see this with a patient is take an x-ray. It's one of the first things you should do is take a periapical. If you see that there is no bone loss, then you can diagnose this, most likely, as being a peri-implant mucositis. And this is something that you can comfortably treat in your own office. If you take a periapical radiograph in this situation and you do see bone loss beyond what you would expect to see, you know, people say about a millimeter in the first year to the first thread, that sort of a thing. But if you see more significant bone loss, then you have to be concerned that you have a true peri-implantitis, and let's call that implant periodontitis to the implant gingivitis, to continue that theme. And that's a very good way to think about these two diseases. I do not feel comfortable treating peri-implantitis in my office. I absolutely would refer this to an oral surgeon or certainly a periodontist. This is going to need surgical intervention. Peri-implant mucositis can often be treated with non-surgical instrumentation, which we'll discuss a bit. But you really need surgical intervention for peri-implantitis to predictably treat it. But the real question, of course, is what's causing it. It's a plaque-induced disease. There are some risk factors, including smoking, including the health of the patient. But unfortunately, one common cause of these implant diseases is retained cement, excess cement, residual excess cement. Why? Because these cements act as a nidus, act as a locus for bacteria. So some literature out there will still use the term peri-implantitis, and I don't like that term. Itis, as you know, implies inflammation, and it's not the cement that's inflamed. What we're really, and it almost implies that it's a separate disease. What I think we're really seeing in what some people would call peri-implantitis is a peri-implant mucositis that has been induced by plaque that is in residual cement, or a peri-implantitis that has been induced by cement that has a plaque that is in the residual cement. So peri-implant mucositis and peri-implantitis are the two peri-implant diseases that we must look out for. What we can do in our office, and then your own hygienist can treat this. I have hygienists that treat gingivitis, so why not have them treat implant gingivitis? It's really the same thing. We will scale with implant-friendly instruments. I prefer graphite scalers. Premier makes a set. These are very soft. They're not going to induce scratching. This is a very nice way to remove residual cement before it is set, and certainly remove plaque that may have accumulated. If you have a very hard and rigid cement that is set underneath the tissue, you may have to upgrade to a titanium scaler. But again, at this point, I'm starting to become a little uncomfortable in treating this because a titanium scaler can certainly scratch the surface, and although it may remove the cement, it will potentially introduce a different kind of nidus for plaque to continue to grow. But I certainly will have a go and certainly try to detect any residual cement using an implant-friendly scaler, such as one made of graphite. I'll then use a local antibiotic. And you know some manufacturers out there. That's fine. I'll put some of that material in. You can also use a systemic antibiotic. We have research that shows amoxicillin 500 and metronidazole 500 to dispense 20 and give them twice a day for 10 days. That will certainly help calm the tissue down. But again, we have to remove the source of this. If this is just a patient who has been negligent in their hygiene, or they have one of those restorative contours we discussed, where they're retaining plaque very easily, then we can certainly start off with this therapy. But one of the things I'll do too is remove the restoration. And if you're using a retrievable cement, an implant cement, like the one Premier makes, then that should be a snap. Just pop that off. You have better access to clean and debride the sulcus and all those, the underlying prosthetic mucosa, all those tissue areas that we were discussing before. And you can then use your local antibiotic and whatnot and get the tissue to calm down, and you're good to go. Of course, if this reaction has been induced by excess cement, then again, you can retrieve the cement, retrieve the restoration, look for the excess cement, and hopefully remove it very easily. Unfortunately, if you have the case where a prior dentist, let's say, used a very permanent cement, say a resin cement or something of that nature, the retrievability of this crown is going to be highly questionable. And if you know for a fact a resin cement was used, for example, that's not a great sign. It's going to be very challenging to remove that. You're going to have to look more at preparing an access hole into the crown, rather dangerous and scary thing to do, and remove the restoration intact and then debride as needed. But again, I can non-surgically treat peri-implant mucositis in my office very comfortably between myself and my hygienist. If I'm concerned about residual cement that cannot be removed, or if I'm concerned about peri-implantitis, then I will refer to a specialist. Now, this is an example of my bad. I had cemented a 3-unit restoration on implants, and the patient had complained of some discomfort in the posterior. So, fortunately, I had used a retrievable cement, and so I popped this off, and sure enough, after probing around a little bit, we saw a good amount of bleeding on the posterior implant. The other two were fine. So I blame myself for this. This is a few years ago, and I used too much cement. I was just loading that crown up with cement and splashing it on there and watching all this excess cement come out, just like we do with natural teeth. And we should realize that we absolutely cannot do this with our implant restorations. Implants are not teeth, and the tissue adaptation of to a natural tooth and the tissue adaptation to an implant is very, very different. More on that in a bit. So there's a reason why excess cement is more harmful around an implant than a natural tooth, and this is a living example. So what we did is we just cleaned around the area. Here you see I'm using a graphite scaler. I used it around the other abutments as well. Here I am cleaning around the area, making sure that everything is nice and clean. And I'm going to use the Premier implant cement, which I like because it's also radio opaque. It'll show up on a radiograph just to give me a little clue if I have used too much. And this is an example of too much. You know, I was evolving in my cementation technique, and I said, oh, I don't have to fill up the crown. I'll just put a little bit around the margins. Well, it was a little sloppy in my application. Here I am cleaning it up with a cotton tip applicator. That's a little bit nicer. But it's still a good amount of cement, and it's right up near the margin. So when I cemented this, you can see that I still had some excess. Now, that's not the end of the world. You can still clean this off, as you can see. Before it cements, before it sets, I'm using the graphite scaler, nice and gentle, to go around the area and clean that up. And the restoration has been fine ever since. However, we can do better. And more recent research has actually studied the different techniques that we can use to reduce the amount of this excess cement in the first place. And this is what I now look for. This is my application technique, and I'm going to show you how I do this. But this is the kind of clean application in a very strategic position that I'm looking for. So let's talk about the different cementation techniques. There's three techniques out there that are quite popular. One is to use a copy abutment. One is to use vent holes. This is becoming a more popular protocol. And the one that I like to use is putting a ring of material near the margin. So the first two have been championed by Dr. Wadhwani, who's put out some terrific material, and I encourage you to read these two articles if you'd like to see a detailed explanation of these techniques. The copy abutment involves a rather complex procedure that I will be honest, I just haven't used. The copy abutment involves taking your implant crown, putting in a die spacer of sorts, and they typically use plumber's tape. You fit that plumber's tape in there somehow, nice and thin, and then you're going to fill that crown with this tape in there with a material such as blue mousse, some quick setting PDS material. You'll then take that off, remove the little tape, and you now have a copy of your abutment with a little spacer around it. Fill your crown, put it on your copy abutment, wipe away the excess, and now seat that on your abutment intraorally. I went through that quickly, and I invite you to look at the paper there that will go into further detail. But I don't know many dentists that do this. It's challenging to get that tape inside the crown. This certainly takes a little bit longer, but it is a technique that's out there. What Dr. Wadhwani is now advocating, a little more recently, he's been doing research on vent holes, and he just recently had a paper that came out that detailed this. What he's doing is leaving the access hole open, not filling it with cotton or composite. He's leaving the screw access hole open, and he's also placing two vent holes. He's researching different amounts. Is 3 better than 2? But right now his favorite technique is to use 2 vent holes and to have them be 180 degrees apart from each other. And this is on the, say, the facial and the lingual of the abutment. And what this allows is for access cement to instead fill the access hole and these 2 vent holes instead of being driven out apically through the tissue. And he's still using a controlled amount of cement. So I think this technique shows some promise. The technique that I use and I've been very successful with is putting a ring of this material around the margin. And this was originally described for natural teeth and PFM crowns, but this technique still works very much around here. This is how it looks. Here's your abutment, and you can see in this case we've used an anatomic abutment, so it's going to be easier to clean in the first place. But here's an example of the crown. This is just a diagram just to help we can look through this and see what's going to happen. Here's the crown that we would be placing. So here's now my transparent crown, and you can see we're about to seat this. And let's say I have that ring of cement. It's not at the margin, but it's near the margin. As I go to seat this material, it starts to stretch and expand, and it runs up towards the access hole. As it runs up towards the access hole, I leave it open. It will begin to fill in there. And that's okay. You don't have to worry about this material now completely filling the access hole and engaging the screw head of the abutment screw. We're using a very controlled amount of the stuff, so it's not going to just flow all over the place. It will first rise apically, and then when it's fully seated, we will then have any residual come out through the gingiva. This greatly reduces the amount of cement that we find. So here's my technique. I actually don't place this into the crown. I place it on a pad, and I then take a microbrush. And this gives me great control applying to the inside internal aspect of the crowns. I can then have a second microbrush ready that's nice and clean to clean up any little bits that may be in excess. You can see here, this is how it looked initially, and I cleaned up any little bits of excess that were present. I will still then, after I seat it, trace around the margins with a implant-friendly scaler, again, this one made of graphite, just to make sure I don't have any little extra bits that may have come out. But I've been using this technique now very predictably. The implant restorations do stay in place, and I found that I have much less excess cement.